topic that we have encountered and we will continue to encounter from time to time in the clinical setting. So without further delay, this is Dr. Sun.
Hi everyone. Thanks, Lan, for the introduction. Do I have to stand close to this?
Oh, yeah.
I guess I'll just get started, and I think I'm going to start by just jumping right into a case that me and Wendy McLeod did on a Saturday night. It was a cesarean section. But just start, does anyone know where the word like cesarean section comes from? I didn't realize this until I looked it up. But this was one of the earliest pictorial, one of the earliest pictorial recordings of a cesarean section done, I don't remember, in Roman times. And it's supposed to be depicting the birth of Julius Caesar, who was supposedly delivered by cesarean section, hence cesarean. But I don't think this was true because they debate whether or not his mother survived, and at that time, a cesarean section was only really performed on dying or dead women. So, and she supposedly lived, the mother. So our case occurred on it started on a Friday morning. It was a 28-year-old, or it is a 28-year-old female who came in post-dates for induction of labor. So around at 11 o'clock and then again at 6 p.m. at nighttime, she got 2 insertions of Cervidil. And from 7 p.m. on to midnight, her pregnancy was progressing relatively normal. So normal fetal heart rate to variable decels with contractions. She had a spontaneous rupture of membranes, and she was about 4 to 5 centimeters dilated by midnight. Around midnight to 1:30 is when things started to take a turn for the worse. So she, around 1:30, had one episode of uterine hypertonus. It was associated with a sustained fetal heart rate deceleration down to the 70s to 80s. And at this point, the OB came in and had given her some nitro sprays and IV nitroglycerin about 4 times 150 mics through the IV, as well as a magnesium sulfate tab to take. But none of those actually had any effect. So around 1:50, the OB called a stat C-section. She went straight to the OR, had a general anesthetic. It was a straightforward general anesthetic, and she was hemodynamically quite stable. 2 minutes later, the baby was out. The surgeon noted actually a small abruption when he went in. The CBC had that was done pre-operatively came back intra-op and showed a hemoglobin of 108, platelets of 193, an INR of PTT that I couldn't actually find and we never actually got, so I don't think they were done. So after the baby was delivered, the rest of it was the closure. And the closure took longer than usual, and the surgeon noticed abnormal amount of oozing. He, for instance, had to put his finger on one of the uterine stitches for almost 30 seconds just to have it stop bleeding. But he did note that the uterine tone was very good. And we debated whether or not to send off a coax because, she's a healthy lady, but it was just odd that she was kind of so oozy. So we decided, for good measure, just to send it off before the end of the case. So the surgery ends, and we're actually getting ready for extubation. She was breathing on her own, hemodynamically stable, starting to kind of wake up. And then the coags come back. And the first set reads an INR of 2.4, and a fibrinogen that was less than 0.7, with a lactate that had risen up to 4.3. Up to this point, she was quite stable for us. But I would say maybe 10-15 minutes after this occurred, she was still intubated at the time. Her heart rate suddenly shot up to 160. Her blood pressure systolic was as low as I think 65 or 69. And she became rather unstable. We did a quick bedside echo because the ultrasound was in the room. And on the transthoracic, the subxiphoid view, and the peristernal long axis view, you can see that she had really no RV strain. It looked like overall that she had good LV function. RV was contracting well. And then in the abdomen, her IVC was barely visible. So we thought this was looking more and more like hemorrhagic hypovolemic shock. And lo and behold, when we lifted up the covers, there was a gush of blood that came from her vagina. Her uterus at that point was still very well contracted, and there was actually no blood coming from the JP drain that the surgeon had put in. So most of it was probably coming from her vagina as well as from her endometrium. The repeat blood work that we did around 30 to 45 minutes later came back at this point, and her fibrinogen was now 0.5. Her INR had risen to 3.4. So today I wanted to talk about disseminated intravascular coagulation in pregnancy. I'm going to just quickly talk about just a review of hemostasis and approach to bleeding disorders. And I apologize if it's too simplistic for everyone, but I thought it would be a good thing to review before we started. I'm going to talk about DIC and specifically about the case that we had, which we believe was placental abruption initiated. I'll also talk about diagnosis as well as early recognition and management and our management of the case as well. So, just a quick review of hemostasis. It's a rather complex process, but this is just, I'm going to go over a quick summary. So you start really with, there's several components. There's primary hemostasis with platelets, which really consists of number one, activation, platelets binding to von Willebrand factor and glycoprotein, causing activation and release of alpha granules that contain factor V, fibrinogen, other things that initiate, that are prothrombotic. The second step is stabilization, whereby platelets bind to each other, and they bridge other platelets to form a plug. And third step, which is inhibition, whereby the endothelial cells produce prostacyclin as well as nitric oxide, which then negatively feedback on the process. The coagulation cascade comprises of the intrinsic pathway, extrinsic pathway converging onto the common pathway. The intrinsic pathway starts with factor 12 and ends in factor 8, and it's produced, factor 8 is unique in that it's produced by endothelial cells and it's stabilized by von Willebrand factor. The extrinsic pathway starts with, usually is some kind of endothelial damage whereby the tissue factor is exposed to the blood, and that initiates the clotting cascade. And these two pathways converge onto the common pathway whereby factor 10 and 5 work together to convert prothrombin into thrombin. And thrombin in turn cleaves fibrinogen into fibrin, which forms cross-links to form a stable clot. So that's quite simple. And then the last part is, of course, fibrinolysis. So plasminogen gets converted to plasmin and breaks down fibrin into its soluble units. D-dimer is what we measure. And of course, through this entire process, we have our anticoagulation factors that kind of clean up after this. We have tissue factor inhibitor with antithrombin 3, which is enhanced in the presence of heparin. And thrombomodulin is also an anticoagulant, combination of protein C and F. So in terms of a simplistic approach to coagulation disorders, we start with platelets. And as you know, platelets, we can have normal numbers, but decrease in the function of these platelets. We can have decrease in the number of platelets, as well as von Willebrand disease. So under decreased function, it can either be congenital, as Bernard-Souliers. You can also have acquired dysfunction, such as with drugs, ASA, Plavix, as well as systemic dysfunction. So if you have renal failure, liver failure, as well as if you run someone's blood through the CPB, cardiopulmonary bypass, you can get that. And with hematologic cancers, such as MDS and MPS, where you get abnormal platelets. The decreased number, the one that, decreased number, you can have several reasons as well. Decreased production from the bone marrow is one, increased sequestration in your spleen, as well as increased destruction, such as with DIC. And lastly, von Willebrand disease. So as I talked about earlier, the von Willebrand factor is important for platelets to adhere to and get activated by. So if you don't have the substrate to activate platelets, it can manifest like a platelet. Under coagulation disorder, it can be congenital or acquired. The congenital ones are hemophilia, von Willebrand disease again, and specifically you get a factor 8 deficiency because again, von Willebrand factor stabilizes factor 8, as well as more rare factor 11 and 12. And the acquired ones are the ones that we're more used to dealing with. You get decreased production of coagulation factors such as with liver disease and shock liver cirrhosis, vitamin K deficiency, use of warfarin. You can also get increased destruction and consumption such as with DIC. And can't forget about the inhibitors, so with lupus anticoagulant and drugs like heparin and your NOAC. And the last thing is, if you're making all this clot and you're breaking it down super fast, you also have issues with hemostasis. So there's a population that have hyperfibrinolytic activity. And again, with DIC, you can get, just going into this area as well. So, in a normal pregnancy, again, a review, you have things that favor formation of less clot, and you have things that favor the formation of more clot, and things that don't really change in pregnancy. Overall, the balance is really tipped towards hypercoagulable state. So what is disseminated intravascular coagulation? Well, it's defined as a life-threatening condition. That's the endpoint of an uncontrolled systemic activation of your hemostatic mechanism that really culminates in one end-organ failure and ischemia due to microvascular thrombosis and uncontrolled hemorrhage due to depletion of your coagulation factors. So in terms of pathophysiology, it's actually quite simple. But when you see DIC, you should really be thinking about what's causing it. It's not a disease in itself, and it's always secondary to an underlying disorder that leads to this uncontrolled activation of coagulation. So the pathophysiology usually starts with exposure of the blood to a procoagulant, and that could be bacteria, it could be a cancer procoagulant, damage of your vascular endothelium, such as with trauma. The second step is initiation of this coagulation cascade. It takes off and forms thrombi and consumes your factors. This is then followed by a period of fibrin degradation. And fibrin degradation products not only interfere with formation of further clots, but also impairs the ability of the uterus to contract down and have a good tone. And in the end, this really leads to end organ damage and bleeding. So in terms of the incidence of DIC and what causes it, it depends on which cohort you look at, but the general picture is quite similar. So the incidence is, I would say rare, like 0.03 all the way to 0.35% in pregnancy. And then of the patients who developed DIC, when they looked at them, about 37% of them had a placental abruption. About 29% had postpartum hemorrhage, I think of any sort, and 6% amniotic fluid embolism. You can see for yourself, but the most common cause being placental abruption. And of course, it's associated with a high degree of maternal mortality and morbidity. So what is abruption? Well, it's bleeding at the decidual placental interface that leads to partial or total placental detachment prior to delivery of the fetus, and usually defined as after 20 weeks of gestation. And the incidence is 0.2 to 1% of all pregnancies. And this is just images I found from the internet showing abruption. You can't see my mouse, but in terms of the mechanism of abruption, there's 4 main ones. Number 1 is mechanical, so any blunt abdominal trauma, uterine compression, any acceleration, deceleration injury that causes shearing of those vessels. Uterine anomalies can do it as well, and that really is due to suboptimal trophoblastic implantation, which can cause implantation issues. So bicornuate uterus, leiomyomas, previous cesarean section scars. Drugs is another cause, and cocaine is thought to do this through inducing vasospasm, causing ischemia, and subsequently reflex vasodilatation, which causes disruption of the vasculature. And lastly, chronic placental disease, such as preeclampsia. So the pathophysiology of this really has to do with abnormalities in the early development of the placenta, especially in the development of the spiral arteries, a defect in that development that leads to decidual necrosis, placental inflammation, maybe infarction, and then ultimately vascular disruption. So just quickly reviewing the structure of the placenta, something I hadn't looked at for ages, but the terminology will become clear after this. So you have the blastocyst, which is really the embryo encased in many layers of undifferentiated cells. And they contain these undifferentiated cells called trophoblasts that differentiate afterwards into cytotrophoblasts. These are cells that actually invade the endometrial arteries, and they cause them to develop into spiral arteries. These spiral arteries are these high flow, low resistance, no autoregulation arteries that allow a lot of maternal blood to pool into the placenta. They also differentiate into syncytiotrophoblasts. They're terminally differentiated cells in the outer layer, and they're in charge of invasion basically invasion into the decidual basalis layer of the endometrium. And they're in charge of forming lacunar spaces that hold the maternal blood and establish the maternal fecal exchange. So this is a colorful yet busy diagram of the placenta in terms of invasion. So here you see, here's the syncytiotrophoblasts, the cytotrophoblast here, and the syncytiotrophoblasts here. And here in this diagram, you see them invading into the maternal spiral arteries, and here invading, creating the lacunar. Okay, so in terms of the placenta, we talked about that balance between less clot and more clot. The same thing applies in the placenta. You have things that favor less clot. So in pregnancy, the trophoblasts actually produce more protein C and S. Again, those they create thrombomodulin, which is an anticoagulant. And they also produce more tissue factor inhibitor protein. Okay? And on the other side of things, you have the things that favor more clot. These syncytial trophoblasts actually express more tissue factor. So in abruption, you have rupture of maternal vessels in the decidual basalis. This could be venous or arterial. Occasionally, you get bleeding of the fetal placental vessels as well. The blood accumulates in the decidua, and it can either be self-limited or cause a splitting or dissection through the placental decidual interface that leads to complete separation. And the detached placenta can no longer exchange gases, causing a compromise to the supply of the fetus. So in addition to the damage done on the fetus, several things are happening in the placenta as well that lead to maternal pathology. So the fine balance essentially in the placenta is tipped to favor more clot formation. So you have the antithrombotic self-regulatory mechanisms which become outweighed by several things. Number one, decidual bleeding can lead to your tissue factor and thromboplastin being released into the bloodstream. Thromboplastin converts more prothrombin into thrombin. You have decidual hypoxia, which can induce your vascular endothelial growth factor production, and this leads to more aberrant tissue factor expression. And this really all culminates into more thrombin generation. And this is just a pictorial representation of thromboplastin and tissue factor being released as a result of abruption. And the key really is thrombin production, more thrombin production and more thrombin released into the bloodstream. So thrombin can, one, act as a direct uterotonic, can cause uterine hypertonus. Number two, it can cause the initiation of labor. If somebody has abrupted much earlier, it can also lead to premature rupture of membranes, and that's through production of metalloproteinases, pro-inflammatory cytokines. And three, it can cause the triggering of coagulation cascade. It can overwhelm the control mechanisms and ultimately lead to this disseminated intravascular coagulation. So, abruption, in terms of symptoms, we all know vaginal bleeding, abdominal pain in between contractions, a non-assuring fetal heart rate, and hypertonic uterine contractions, and a woman that looks similar. So in terms of the diagnosis of DIC, early recognition is really key, and I think it's important to also recognize that there's really different forms of DIC. There's the acute ones that we're really used to dealing with. They're acutely ill patients. There's rapid progression of DIC, something that really triggers it in the snap of your finger. They're in DIC, and requires really immediate intervention. You have your more subacute presentation, which is in between acute and chronic. And the chronic DIC patients are these mild, protracted courses of developing DIC, and oftentimes can be a result of multiple mechanisms. So in terms of early recognition, I didn't realize this, but there's actually some scoring systems out there for you to grade whether or not somebody is at high risk for DIC. So I don't know if you can see this very well. Probably not. So there's two scores out there. There's the ISPH and the JAM, J-A-M score. And they both look at very similar things. So they both look at platelet count. They look at fibrin-related markers, such as D-dimer. They look at the prothrombin time, or INR. They look at fibrinogen level. The JAM actually looks at an extra one, which is the SIRS criteria. And they calculate a score, giving you a high or low likelihood of progression to DIC. But I think looking at this, you can see that there's already several issues with this scoring system. So several pitfalls. First of all, the values are not based on the normal values for a pregnant woman. The platelet count, as you know, in pregnancy can be normal in the face of DIC, such as with our lady. Her platelet count was actually quite normal up until much later in her disease. Or the platelet count can be low, and that can be confounded by gestational thrombocytopenia. Okay? The INR PTT are considerably shorter in a pregnant woman than compared to the general population. And studies have shown that even after 1,500 mils of blood loss in postpartum hemorrhage, the INR is normal in about 98.4% of women. And the prolongation of PT, the INR, and the PTT may not occur until the underlying disease progresses has advanced considerably. So that will be much too late. So what they've done is they've modified the ISTH score for pregnant ladies. And I think the main things to note here are, well, the sensitivity is 88%, specificity is around 98%. And the main thing that they really changed is that the INR-PTT cutoffs are different. And you gain points for DIC if your fibrinogen level is less than 4. And you get, and you actually get assigned points. You get assigned 25 points if your fibrinogen is less than 3. And you only need a score of 26 or higher for a high probability of DIC. So we put a lot of emphasis on fibrinogen. So again, like utility. Interestingly enough, talking about fibrinogen, there is evidence behind it, and we've all seen it. In Charby, a paper, this person did a prospective multi-center study in Paris, and they analyzed the blood work of 128 pregnant women who had a PPH and were requiring a uterotonic infusion of prostaglandin. And they found that fibrinogen levels of less than 2 had a positive predictive value of 100% for progression to severe PPH. And fibrinogen levels of 4 had a negative predictive value of 79%. So I think this just kind of, again, emphasizes, yeah, sorry.
On the previous score, then, is it correct that platelets less than 50 is actually less predictive of DIC than?
Yeah.
Because platelets can be less than 50 for other reasons.
Right, but you would still think it could just be this is really an evolution, the DIC. I'm surprised it'd be less than I could see it not adding to.
Did you get the understanding that basically what it says is that if you've got that with a lowish or less than 3 fibrinogen, it's almost 100%.
Okay.
Yeah, exactly. I was confused by that too, Dr. Carey. So I tried looking it up. It didn't specify in the paper that I read, but I think they did mention other things. So they say that in DIC, rarely are your platelets the main issue or the main concern. They say that if your platelets are so low, you should be thinking about things like HUS, TTP, and other things. I think that's the main thing, because they actually award you like, so there's 0 points if you're above 185, but they give you 2 points if you're anywhere between 50 to 185. So I think it's just, maybe it's just not like a pathognomonic hallmark of that disease. And again, if your fibrinogen is high, like you only need 1 point. Again, it's not like, I don't think it's the greatest scoring system. Is there any other questions?
Yeah. Did you find a transfusion trigger, or not a transfusion trigger, but a cryo trigger in pregnant women?
We have one here in our massive transfusion protocol.
Is it greater than 2?
Yeah.
Yeah. Okay.
Yeah, that's the one that we use.
Yeah.
Good question. All right, so diagnosis of DIC. So back to diagnosis. So I don't think the scoring system is the best system. I think that's why we really haven't used it. If we can just recognize fibrinogen as key, I think that's really all you really can take from that. But what about thromboelastography? Well, just quickly, again, a review of thromboelastography. It looks at coagulation of whole blood. So whole blood basically goes into a cuvette, as you can see there. And you have like a cylindrical pin immersed in this cuvette. And there's about a 1 millimeter gap between the pin and the cuvette, and the pin is rotating. So it really, so as long as the blood is liquid, the movement is uninhibited. But when the blood starts to clot, the rotation becomes more and more restricted. And this kinetic change is detected and translated into basically a graph with parameters that are interpreted. And it gives you a wealth of information. It provides information on platelet function in the intrinsic and the extrinsic pathway, as well as your fibrinogen function. So there's TAG and ROTEM out there, and the difference between them is very simple. One is a rotating cuvette, and the other is a rotating pin. Initially, TAG was I think the TAG was a rotating cuvette with a freely suspended pin, and it was just really sensitive to vibration. So they developed ROTEM, which has a fixed cylindrical pin and is less sensitive to movement and vibration. So in terms of the data, there's actually very limited data on its use in pregnancy. There's a paper published 2011 which compared pregnant to matched non-pregnant females, and they did their whole blood, they put them in the ROTEM, and they measured their coagulation. And it clearly demonstrated that they were more hypercoagulable in pregnancy. And I found, well, just to quickly review what the graph that you produced looks like. I'm by no means an expert in this, but basically you get the alpha angle, which has to do with, which they look at for platelet function. Your MCF is your maximal clot firmness, which is the thickness there. And clotting time, the time it takes for initiation of the clot. And clot formation time as well, which is also reflected in your alpha angle. So this is a diagram that I found in Chestnut, and I thought it was pretty remarkable because you can see the solid line here, that is group 1. So group 1 is non-pregnant females. And the second one above it, group 2, are women who are pregnant but not in labor. And the one above it is women who are pregnant who are in labor. So this, the ROTEM actually has the ability to distinguish between the same population going through different cycles in their pregnancy, so one in labor and not laboring. And as you can see, women who are pregnant who go in labor actually become more coagulable at that point. So I thought it was pretty remarkable. So again, this is just, I'm not going to go over this too much, but this is a normal, this is somebody with normal ROTEM. This is somebody who has a reduced alpha angle, could be indicative of platelet dysfunction. This is one where you see very little fibrinogen. This is one where you see too much fibrinolysis. And this is an intrinsic clotting deficiency, the intent. Okay, so back to our case. So intraoperatively, we initiated massive transfusion protocol. And by the end of the case, which lasted from around 2 o'clock until, I would say, 6 a.m., we're managing her intraoperatively, intubated, put her back on sedation, ventilated her, and trying to get her out of this DIC. We gave her about 10 units of packed red cells, 10 units of FFPs. We gave her 30 of cryo, which is 3 bags of a cryo, 2 of pooled platelets, which amounts to about 12 total platelets, 2 grams of tranexamic acid. And initially the surgeon came in and he said, there's not much, we can't really go into the abdomen. This is all probably medical bleeding. And he was right. I mean, there's nothing coming out of the JP drain to suggest that it was intraperitoneal bleeding. The uterus was really well contracted. There wasn't really much to do with tone either. So he tried to fit a Bacri balloon for whatever it was worth, but actually couldn't even get the Bacri balloon to stay in because the uterus was so contracted down. Because I forgot to mention we gave her ergotamine and some of the aids as well. And in the end, he just put in vaginal packing. And ultimately, I don't think that did anything. I think ultimately it was the correction of a DIC that really turned him around. So in terms of management of DIC, I'll just quickly go over this because there isn't it's a really just supportive care with transfusion of blood products and related measures. So, I mean, there isn't any studies done on pregnant women. I don't think there ever will be. But there's the 2 ratios that were compared, the 1:1:1 versus the 1:1:2, the plasma platelet RBC ratio. And the only real study that we have of this is from the PROPER trial, which is in trauma. And they found that there's no difference in mortality between these 2 ratios, but the 1:1:1 did achieve hemostasis and fewer deaths by exsanguination at the 24-hour mark. So, and that was something that we decided to just try to stay as close as possible to, and ultimately, I guess we did do more of a 1:1:1. For tranexamic acid, again, there's little evidence for its use in postpartum hemorrhage, but it is recommended as a consideration in the case of intractable BPH. And factor 7A, something that we didn't give, but there's actually a study that shows that human factor 7A does reduce the need of invasive second-line therapies in severe refractory postpartum hemorrhage. And second-line therapies being interventional hemostatic procedures such as uterine compression sutures, like the V-Lynch sutures, ligation of the uterine or iliac arteries, uterine artery embolization, postpartum hysterectomy, and Bacri balloon even. So in this study, they actually recommend going to factor 7A relatively early. But of course, it's a double-edged sword. You do get a 2 times risk increase for arterial thrombosis, and that's what limits a lot of its use. Current guidelines saying that you can use this prior to proceeding with a hysterectomy, or should try it prior to proceeding with a hysterectomy. And of course, if a patient is severely metabolic acidotic, there's very limited use. for this because the efficacy is reduced. And of course, she went to the HAU. Well, she stayed intubated in the PACU for only about maybe an hour, 2 hours after we left, and then she was extubatable. She stayed in the HAU for a couple of days and subsequently was discharged. And I think she was discharged September 17th. Okay, so this is a poorly, excuse me for the, I'm using my phone, I don't actually have a scanner, so.
It's a healthy pre-printed order.
It's a pre-printed order for the massive transfusion protocol, and I didn't even know it existed, but it's very helpful. It's an excellent guide for yourself and as well as the nurses and all the staff, just to keep them on the same page. It basically gives you criteria for like how to manage initially, their transfusion orders, how to activate the massive transfusion protocol, what laboratory tests you should be doing, and they're just like triggers, like memory aids to trigger you would think. And this is the form that the nursing staff fill out for the massive transfusion as well.
I asked Terry to put this in because that form is different to the form we use just for regular transfusion. So it's a little more complicated for the nursing staff to fill out because they've got to fill out all the blood in one area, all the platelets. So it allows us to count up what we've given and where we're at. And it's only being used for massive transfusion, not for regular transfusions. And this other massive transfusion protocol is being used on labor and delivery. So if you do happen to go to a massive transfusion on labor and delivery, and hopefully we get called earlier rather than later, in theory, they should have started using this protocol.
I think this actually hasn't been used much, right? Because I've been involved in 2 massive transfusion protocols, 2 or 3 in the last like week and a half, and I haven't seen this form, and I haven't seen the nurses filling it out.
Was it started in the
One
case room?
The one was started.
Okay,
No,
so
one
what
was
we
emerged.
did is we did not apply this to the OR because in the OR we're anticipating that an anesthesiologist is involved.
Okay.
And it was felt in discussion with Doug Morrison and various other people that that's what we do. So
Yeah.
we should know what's going on. If somebody wants it pulled out, it can be easily pulled out and you can carry on going through the motions. So we are in the process of developing, and I'm not part of that process, but they are in the process of developing one for the OR. But this is available for anybody who wants to use it.
That was very comprehensive.
We have recommended, regardless of the evidence is soft on tranexamic acid, but we've recommended that it be used.
And the one that you got for emerge, I mean, this is for traumas and emerge.
Yeah.
But they don't always think to print out the protocol.
Yeah.
Sometimes the chaos down there, it takes someone to say, print
Yeah,
out that protocol.
because I found it hard to see how much the patient had an emerge. I had no
I didn't
idea
know about
really.
that form that we have to track.
Well, in the OR, I don't know what happens in emerge, and the nursing staff are tracking that for us, and I've got to kudos to them, they were phenomenal. We had PSU staff in, as usual, because there weren't enough other staff, and we were in the middle of another case when this happened. So, yeah, they were, and the lab was amazing because they had another massive transfusion from emerge at the same time, and they managed to get our results back on time, and we got our blood in a timely fashion. It was
The entire hospital is now on hydropower. If you have any power
It took
problems,
only like 30
please
minutes
contact
to get on the
facility
file when
maintenance.
we asked, right?
Yeah.
Like,
but we had blood up within
Blood up,
15
yeah.
minutes. Yeah, and
Shouldn't take something.
So in terms of her post-op course, it wasn't actually like fixed, gone, good. It was a little bit complex actually. So she was extubated, she was on the HAU. She was doing well clinically, but in terms of her laboratory values, so several things were kind of amiss. The first thing was her creatinine actually rose thereafter. So several reasons that we thought could have been the reason. Number one, her kidneys could have taken a hit. She wasn't hypotensive for very long, and she was hemodynamically, for the most part, stable, but it's a possibility. The other possibility is all those degradation products, the fibrin, all the garbage just clotted up her glomerulus and caused maybe a pre-renal AKI, which might have progressed to an ATN because her creatinine actually rose up to 190, and it stayed up, and it's still, on discharge, it was still 122. Her baseline was completely normal. So that was one thing. The other thing was her platelets kind of took a dip after we dropped her off in the PACU. So her trough was, I think, as low as, oh, it didn't say here, but I think it's like below 75, so maybe around 60 or so. But it went up thereafter, so we think, again, it's maybe just some residual consumptive processes going on. In the ICU, they did entertain the idea, and hematology was actually involved in the potential diagnosis of HUS versus TTP. But again, it's really hard. It will be really hard to tell or distinguish those syndromes apart. And preeclampsia was still really on the menu. She was never hypertensive, but you really don't need to be hypertensive to necessarily exhibit symptoms. And they did do liver enzymes and they did do uric acid, but all of that is really confounded because they were done post this event. So her liver enzymes were slightly elevated again, could have taken a bit of a shock. Her uric acid was elevated, of course, she had hemolysis. So in terms of diagnosis, because we didn't have really good baseline values, it was very difficult to interpret. And we think, common things being common, it was probably the placental abruption. We had clear clinical signs that it was placental abruption, leading to DIC and the creatinine climb results of the degradation products from the.
Yeah, I mean, the interesting thing is her lactate was quite high on that initial blood work before you said she destabilized.
Exactly.
So she was already compensating.
Yeah, exactly.
And interesting though, she was not hemodynamically unstable. She was hemodynamically unstable. Her blood pressure dropped, and we decided when we got those results back, we're going to start a massive transfusion protocol because of the DIC, even though we'd seen oozing, and the reason I did the blood work was because Doug was futzing around, and Doug never messes around. He gets on and does it. And I came into the room from finishing the other case and said, "What's going on?" And Doug said, "It's easy." And I thought, you know what, there's something going on here. It was just a gut feeling. It wasn't anything else. And we sent that blood work off. And then when we decided on the massive transfusion protocol, she had that brief episode, but the rest of the time, what was remarkable in her is no hypotension. And that's why it's interesting to see what happened to her creatinine. And I think what we really lack insight into is the effect of inflammatory mediators from a process like probably some underlying PIH, but and the abruption that create an ongoing issue, even though the DIC is apparently stabilized. This is a long-term process, and it's a whole body process, an endothelial basically reaction. Because really I was surprised to see that lactate like it was in the face of a hemodynamically stable patient.
Yeah, so that's scary.
Yeah.
That,
That's really.
So maybe I missed this, but how much blood did she actually get? How many units?
10 units.
10. So you said the uterus was contracted and there was very little bleeding. So was all
There
her?
was a lot of bleeding.
Oh,
yeah.
from where?
It was from the vagina.
From the vagina, I think it was the endometrium, and it was just all oozy bleeding. Like she had a continuous trickle from her vagina, despite the uterus.
So was there also a component of
odd.
hemolysis, do you think?
You mean, for sure there was a component of hemolysis. Yeah, absolutely.
I think, Peter, with the abruption, and I mean, we always used to just say, because we saw a lot of these in septic abortions in South Africa, is they get this cuvulaire uterus, this hypertonicity.
Yeah.
And I think that's what we were dealing with. We had a hypertonic uterus, which becomes hypertonic as a result of the thrombin release. And so you've got a contracted uterus, but you've got a surface that is just pouring. So regardless, and that's, I think, why he struggled to get the battery balloon in, because the uterus was so contracted, but just this raw surface, even contracted, it was pouring. I mean, I have never seen so much blood coming out of it. And when we put in a central line, her arc line, she was just pouring from everywhere.
It's just in my own experience, most of these cases that I've had, not that I've had many, it's always been the uterus has just gone blah, and everything's been just flowing out and you're struggling to get the uterus contracted. I haven't seen one like this where the uterus was so tight and yet bleeding.
Yeah, no, she was really tight, and he tried a couple of times to get the battery and just kept slipping back. And but she was pouring vaginally, and obviously from sites and stuff like that. I mean, we had to retape her artery line about 4 times, just kept pouring out of our artery line.
It sounds like a red herring because it ends up being a purely hematologic and endotheliologic problem in the context of an obstetrical operation.
Yeah.
Which is really misleading.
It would sound like a hysterectomy in that situation would be much less likely to be successful because it isn't a non-contracting uterus that's the issue. But,
Although we do have ongoing bleeding, I mean, if you could stop the bleeding, because we spoke about should we be going to embolize her, but at that time I didn't want to be moving her because we were still pouring in product. The problem was the bleeding surface. You know, if we could have got rid of the bleeding surface, although going back into the abdomen may have caused
yeah, all those arteries and everything would be bleeding like stink too, presumably.
But I mean, a couple of things in the differential diagnosis, you're going on to do that, aren't you?
Oh, no, I'm not.
Come on, aren't you trying to be ambitious? Do a big talk? Come on.
Oh, okay. Well, do you want to chat about the differential diagnosis? We did go through the whole differential diagnosis of what could this have been, and was this just an abruption, probably in the background of an undiagnosed PIH, but was this an amniotic fluid embolus? But there was no hypoxia, 100% saturated in spite of all of this stuff going on. Blood pressure, except for that one gush where I think we got behind on fluids because we didn't know she was bleeding. The rest, so it was a very bizarre case of a stable patient with just pouring.
But that's one of the takeaway points of this, right? Like they can lose 40-50% of their blood volume and still be looking at you.
Oh yeah.
Like, well, although she was asleep, so she couldn't be looking at you.
Yeah.
But that's
If you didn't tape her eyes.
amazing. A lactate that high and hemodynamically, quote unquote,
Well,
stable.
I think the DIC process probably contributes to that high lactate as well with the disseminated intravascular coagulation, because she, if you looked at her periphery, she wasn't shut down. She didn't have those signs of somebody who was on the edge. She became tachycardic and hypotensive for a brief period. Then her heart rate came down, everything. It was, I mean, had we not had this blood work, had we not decided to do that, I can tell you she would have crashed in the PACU because she looked great. For a very short period of time.
Except for the bleeding everywhere.
Yeah, but that came like after, we waited for the blood work in order to decide whether we were going to extubate her because she was looking so good, and then blood work came, then blood pressure dropped, and then everything.
It just reminds me of a case I had years ago by myself at 3 a.m. in the morning of a young lady who had a postpartum hemorrhage, and the most prominent feature was, in spite of blood just gushing out, and tachycardia, her blood pressure was like 160/100 until I had to induce her, and then everything just disappeared. And so, hypotension is a very, very late sign in young, healthy people.
And I got here a bit late, so I might have missed it. Considerations for regional versus a GA off the bat, had it just been fetal heart rate was so low that you had to do a GA?
So when she was getting wheeled, so basically we were finishing up a case about to extubate someone, and Dr. Waterman was wheeling the patient into the OR. And
but he had been in the OR before that to come and say to us, I've given this woman nitro, I've given her this, she's got a hypertonic uterus, I'm concerned. So we said, get everything ready, and the next minute he was around the corner.
And the baby's heart rate was like 70 in the OR when they checked, so he's like...
It worked out well.
I know, and the worst part is it was a 1C lap chole that we decided to do. We chatted to the nursing staff, and I said, you know what, if we do this, something's going to happen, and sure enough, fortunately it happened at the end of the case. But it's that concept of we are on the edge in the operating room at the Columbian, and doing 1Cs in the middle of the night is probably not the right thing to do until we have more nursing staff in place to allow us to open a second room without a problem.
I'm just going to quickly wrap up with this, but basically what happened to the baby, there was like this woman, but the baby. So the baby came out flat, needed some neonatal resuscitation. The core pH was 6.86. and they were querying perinatal asphyxia versus sepsis, but the blood cultures were negative, so it was probably asphyxia actually. And I didn't go over it, but like the placental pathology came back and it showed abruption probably. So there were focal acute inflammation with pigmented macrophages, fibrin deposition at the interface. So that the APGARs initially were quite low, 3 to begin, up to 8 after a while. Didn't require intubation, went to the NICU on CPAP, and actually was discharged a couple days later doing very well, neurologically appropriate. So happy ending on the baby side for now. So in conclusion, quickly, so pregnancy is a very hypercoagulable state. You get increased platelet activation, decreased negative feedback on your anticoagulation systems, and decreased fibrinolysis. DIC is a clinical syndrome describing an imbalance between an imbalance in your hemostasis, and organ ischemia and controlled bleeding are your outcomes. And the most common cause of DIC in pregnancy is still placental abruption, though the cause might not always be obvious, as we discussed. The primary mediator in the pathophysiology of abruption instigating DIC is thrombin, as well as tissue factor. Early recognition is key, but just be cognizant that the healthy pregnant female has really altered norm, and especially with regards to fibrinogen and their PTT and INR being usually lower than the normal. And ROTEM potentially might play a role in the future for diagnosis, early recognition. And in terms of management, well, it's mostly supportive with appropriate transfusion ratio and correcting the underlying cause. And that's it.
I'm sorry I wasn't here at the beginning of your talk. I was at a different meeting, but I just wanted to thank you for presenting at our first resident-led rounds.
Yeah.
I've seen you talk twice now in the last 2 weeks, and again, it's an excellent job. We'll be doing this more frequently for our department, having residents present as they rotate through. I think it's a really good opportunity to practice presenting topics, medical topics in front of an audience. And I think the value for us is very high because these are good cases, and the insight of our residents is important to our learning as well. So thank you very much.
Thank you. And thank you, Whitney.
Thanks, Whitney, for supervising.
Very, very thorough